Good morning, everybody, and welcome. And we're going to be talking today about the drug oxygen. I know it's kind of like weird. We got to have it. Can't live without it. But it is a drug. It is technically listed as a drug. Technically, you have to have a prescription for it if you're getting it other than the natural sources. So, again, we use it for emergency procedures requiring additional oxygen. That's the reason that we use it as a gas for inhalation. And again, just remember that, hospitals do charge for this, believe it or not. So again, we give additional oxygen to increase the amount of oxygen available for the alveoli to have the gas exchange, and then therefore it reverses hypoxia. It also assists with displacing the carbon dioxide, so it helps offload the carbon dioxide and getting it back into the system, oxygen back into the system. And again, in order to make adenosine triphosphate in the citric acid cycle, you have to have a supply of oxygen. So this is why this is very critical for our life functions. So again, it's an immediate onset. Usually the oxygen lasts about 2 minutes. With that being said, it does take a little bit of time for oxygen saturations to come up. So if you put somebody on oxygen, you're probably looking around 30 to 45 seconds before you see any changes at all. And it could be delayed as much as 4 to 5 minutes before you actually see that. So, and by the way, if you're seeing oxygen saturations dropping, remember it took 2 minutes to get there. So something to definitely keep in perspective. So again, we usually use it for people having trouble breathing. If they're having chest pain where we think that there is a cardiac event going on, we provide a supplemental oxygen so that as much of the tissues can get oxygenated as possible. And again, the same idea with shock. We want to make sure that every red blood cell has plenty of oxygen in which to use. Now, when I was coming up, there wasn't such a thing as too much oxygen. And over the years, we found out that is definitely wrong. Matter of fact, so the current guidelines is a saturation of 94 to 99%, not 100%. And the reason for that being is that if you go too high, you have a percentage of oxygen level in your bloodstream that begins to produce free radicals, and which can cause additional problems. So 94 to 99% on our pulse ox is what we're gunning for. Anytime the patient, of course, is in cardiac arrest, any shock state, if they have confirmed or suspected carbon monoxide poisoning, we want to give them as much oxygen as possible. And the idea is that helps displace the carbon monoxide. Now, the problem with that is that carbon monoxide attaches to hemoglobin molecules far easier than the oxygen molecules do. And matter of fact, it's very hard to get them off. That's why we use hyperbarics to help force that off. Okay, anything that's going to decrease tissue oxygenation, any shock state, any septic state, those things we want to do it. And be careful with your strokes, though. Again, usually the strokes, if you give too much oxygen, one of the things, the bad things about giving too much oxygen, by the way, is it causes cerebral vasoconstriction. And of course, that reduces blood flow to the brain, and you don't necessarily want that. So again, respiratory side effects, again, reduced respiratory drive in our COPD patients. Normal people work off of if their carbon dioxide goes high, then you breathe faster. For COPD patients, when their oxygen levels drop, they breathe faster. But then if their oxygen is high, then they slow down or even stop breathing. But again, do not withhold oxygen because of that possibility. Do not. Folks, it is very difficult in the pre-hospital setting with someone having respiratory distress to actually shut down their respiratory drive. And if they do, we ventilate them. So again, keep that oxygen coming. It will dry out the mucosa, so don't become like this lady down there. So you definitely don't want to do that. If you're going to do a long transport for probably more than, say, an hour, and you have the ability to humidify your oxygen, that is a good idea. So contraindications, there's none in the pre-hospital setting, and it should not be withheld from any critical patient. Again, and there's really, again, just give the oxygen. If you think that the patient needs it, gives it. And don't sit there and try to guess whether or not. Put your pulse ox on. If you don't have a pulse ox, your pulse ox is not working, it's better to give more in a short term than not to give it. Okay. Now, I will give one warning about using it with neonates. And these are guys that are less than 28 days, especially very newborn babies that are not used to oxygen. And they're not. If you stop and think about it, they've been in a fluid filled, and mom has supplied all the oxygen for that 9 months of development. One of the biggest problems with giving too much oxygen is that you can detach their little retinas, and you can blind them very easily. When neonatal transports, matter of fact, they use kind of a heliox system, which is what you see these little tubes over here. It's the heliox mixing with the oxygen. And the long and the short is guys, don't blast these guys with 100% oxygen. Try room air first and ventilate them. If they still are hypoxic, then increase the oxygen, but do so in a gradual way, because if you blast them with O2, their little retinas will detach. You will essentially blind them. So you don't want to do that. Okay, now, again, drug interactions. Again, there are really none. Just remember that, guys, oxygen with a heat source combined with fuel makes fire. And long and the short is yeah, it will go boom. If somebody is smoking in the house and you've got an oxygen tank, be nice and ask them, hey, can you put that out just while we're using this oxygen? Because again, it will blow up. So some side notes of this: restlessness may be an important sign of hypoxia. Just remember that. They're agitated. They're doing weird things. Just again, double check that, and also check their CO2 levels as well. Again, O2 along with cigarette smoking usually ends up in pretty boom there. So again, your oxygen toxicity is seen after 24 hours. We've already talked about the neonate thing. And again, may reduce or eliminate the size of an infarct due to myocardial infarction. It's that collateral circulation that you're helping to feed, and which can reduce the area of the damage that's being done. Nasal prongs work really well on the nose and the mouth breathers. So if you got a patient that's like, I can't take that thing in my nose, and they want to stick it in their mouth, don't fret about it. Put it on there. It's okay. Now, O2 cylinders, right? And this one's kind of important to know. So you got to know the different size cylinders. The biggest ones that we use in the emergency setting is the D, which is your really small cylinder. E is a little bit longer. And then your main tanks, which is your M cylinder, or either your M cylinder or your K cylinders are what are usually used. And again, there's all kinds of different once you get up past, but the big for the portables is D and E is the ones we use. And then the M and the K are usually the ones that we use for EMS. Now, with that being said, this is how much oxygen you have: 406 liters in the very tiny D cylinder, 660 in your E, 2,500 in your K, and 3,000 in the M. And these can be actually higher if they're on a higher pressure system. More pressure, more volume that they've got in there. The key thing is that you're giving liters per minute. So if I'm giving 15 liters a minute on a D cylinder, okay, a D cylinder, 15 liters a minute, so that's 30, 60, 90 in 6 minutes, and I can get, 24 to probably around 25 minutes or just a little bit longer from that. Now remember, you do have a safe residual pressure of 200 psi. We'll talk about that here in just a second. But again, it's really hard. Again, very, very rarely do you need to take a O2 device above 15 liters a minute. And if you do, you're really cranking it up, just remember you're eating up your cylinder when you do that. And a lot of that oxygen is just going out, probably going into the cabin, which is probably helping you a little bit. So again, 15 liters is usually fine, unless they're like really collapsing that bag, then you can turn it up. But again, you got plenty of time is the point. Now, with that being said, if you left your O2 tank at 1,000 psi, so that's about a third of its capacity. So you only got 100 liters in your tank, and you get a really bad critical patient. Well, you've got 6 minutes of oxygen use using that little formula that I just gave you. And speaking of formulas, we'll talk about that. To do the simple math on this, though, small tank, less time, big tank, more time. But just make sure that you got plenty of O2. If you're going to do a ventilator transport, make sure the thing is full before you leave. Make sure your mains are full. Make sure that your little tanks have 2 full tanks on it, and maybe take an extra one just in case. Especially if you're doing a vent transport or using CPAP. And by the way, check your settings on your CPAP. Long and the short is you don't have to burn up that much oxygen. But if certain systems, if you set it to 100% O2, you are going to burn up that O2 tank pretty quickly. Okay. Now, once you hit 200 psi, the bottle is not going to deliver what it's supposed to. So keep your psi above 200. That might be a quiz question a little bit later. And when you're doing O2 calculations, make sure that you account for that residual pressure. And if we're doing that, there's the different constants, and that's the thing I want to show you here. So if you want to make sure that you got it, there's the formula. You'll probably never need to know it, but if you just Google, I need an O2 tank formula, O2 tank math, and this can give you a roughly about how much time that you've actually got. Again, my little math that I just used a little bit earlier, again, is the same thing. It's the same derivative that I used. But again, this is that formula that we're going to use if we were to calculate it. All right. So again, I don't expect you guys to know this, but again, make sure that if you're going to do a long distance transport, you keep that in the back of your head as far as what you're going to need to do. Now, adult dosage. Okay. Again, titrate to effect. All right. If they're in a lot of distress, moderate distress, high flow, 8 to 15 liters a minute. Mild to medium, 4 to 6. Mild distress, you just want to supplement just a little bit, 1 to 2 liters a minute, okay? And then again, but the goal here, titrate 94 to 99, all right? 94 to 99, I can't stress that enough. Don't go to 100, and if they're below 94, they need some help, okay? So, yeah, that is probably true. You get ready for that. So again, your the way that we give it, again, nasal cannula is 2 to 6 liters a minute, a simple face mask 8 to 15. We don't usually use the simple face mask in EMS. We usually use a non-rebreather. Again, those are 10 to 15 liters a minute. Any mask, by the way, any mask has to be at least on 6 liters a minute to fill it. Okay. My favorite thing is getting to the nursing home and we got them on a non-rebreather at 2 liters a minute, but now they're hypoxic. Yeah, you're right. They are. Okay. So again, your handheld O2, handheld nebulizer is usually going to be about 5 to 10. Usually we set it at 6. That's kind of your sweet spot to deliver. Now, some of the other devices that we are going to use, and you may actually be tested on it when you get to like National Registry. Again, this is an oxygen humidifier. So if they're having long-term delivery of oxygen therapy, this again goes on the O2 tree, and then this is your outlet port, but it just simply gets some moisture in there so it doesn't dry out the nose or the mouth too bad. Again, CPAP devices right here. Again, the pressurized device. Most of the ones today are disposable, and they plug straight in. Usually you get 10 of CPAP by turning it to 10 to 12 liters per minute. This is a FroPod, a oxygen powered delivery device. Very rarely are those used nowadays in the pre-hospital setting. You might still see some in an emergency room or a anesthesia setting, but again, most of them use the anesthesia bags. The difference between an anesthesia bag, by the way, and the bags that we use, the anesthesia bag is actually filled by the oxygen delivery system. It doesn't self-fill. Ours actually self-fill. The bag valve mask will be a self-delivery device. And then these again are Venturi masks, and we control the amount of oxygen concentration based upon the little adapters down here. So the adapter attaches down here, and then it attaches in this little piece right here, and they've actually got a reader on this one, and then it attaches to the face mask. So we can actually deliver a specific concentration of oxygen. Our COPD patients, we definitely use this. We use it a lot. You may be picking these up for a transported patient, and if you do so, get with the respiratory therapist to find out what they're on and what liters that they're a minute. The chances that you're remembering blue is the worst and green is the best the chance of you remembering what those numbers are very slim, but usually they'll have it written on the side of them. Just remember, blue is bad, green is good. Okay, and then that's your concentrations are there: red, yellow, orange, white, and then blue. It's kind of my little way. 2, 4, 6, 8, 10 to 15 is the number on it. So again, just get with the respiratory therapist and ask them what concentration that they're at. And usually when you're recording and charting that, you're going to say, yeah, this was a patient that was on a Venturi mask at 60 liters a minute or 60% FiO2. And that's the percentage, the fractional input of oxygen is what FiO2 means. All right, so that's it for the oxygen delivery. And again, oxygen, very important to our business. And especially they've changed the way that we've thought about oxygen. So keep that in mind. Don't blast them with oxygen. Just simply give them what they need. And we want to get that O2 sat between 94 and 99. All right, gang, we'll talk at you next time.